Välkommen till podcasten Psykedelisk vetenskap. I det här avsnittet har Gustav pratat med Roberta Murphy som är psykiater och psykoterapeut och Ashleigh Murphey-Beiner som är psykolog. De är båda medlemmar i Imperial College Centre for Psychedelic Research och har varit terapeuter i psykedeliska behandlingsstudier. De har också forskat på terapeutens roll i psykedelic-assisterad terapi.
Och jag har ju försökt få hit både Ashleigh och Roberta till Sverige ända sedan jag läste deras forskning på det här ämnet. Så det var så roligt att få träffa dem och prata med dem och höra om deras forskning och erfarenheter. So, could you please tell us a bit about yourselves for our audience? What are some things you've been working on in the last few years?
Yeah, so myself and Ashleigh originally started working together on Psychedelic 2, which was a trial for psilocybin compared to some antidepressants. Since then, I've gone back to the NHS and I've continued my training both as a psychiatrist and also as a therapist. It's a special training that you can do in the UK called medical psychotherapy. I've helped guide on some other trials and trained some other trials as well for psychedelics. So there was an eating disorder trial ongoing. I wrote a paper looking at the therapeutic relationship in psychedelic therapy, which is something that we're both, I think, really interested in thinking about. We also run an ethics reflective space together, and that's something I think that we're both currently quite interested in, which is thinking about the sort of conduct and the kind of nitty-gritty and the ethical challenges and clinical challenges of psychedelic therapy. So yeah, I guess otherwise, there are other things that I'm interested in. I've done some trainings in some psychoanalytic institutes and also nature therapy. Yeah.
Cool. And Ashleigh?
Yeah. So as Roberta was saying, we started out in this working in the psilocybin for depression clinical trial. And I've become also really interested in the research side of things. So I've been doing some qualitative research with patients who've been taking part in a treatment for anorexia with psilocybin and DMT for treating depression. And I've been also training as a clinical psychologist, and as part of that, I've been carrying out research, trying to understand more about how we work with people with more complex trauma histories in psychedelic therapies. I suppose that's my area of kind of special interest that I'm trying to think about at the moment. So that's been, really interesting to do over the last few years. And with Roberta, just thinking a lot about the ethical and clinical realities of the work and how we can support practitioners in ways that we felt, I think, that we needed support when we were guiding. I think that's where a lot of our work has kind of grown out from, kind of reflecting on our own experiences and how we might support clinicians in the work.
Yeah, great. That's really needed, I think. So I'm very happy that you're doing this work. But to get more personal, so how did you know each other? Did you meet during the trials or have you been working together before?
Yeah, we just met on the trials. We both sort of were hired from quite different sort of corners of the sort of trial lead's life. And it's been really nice, actually, in lots of ways. We've sort of grown up together as clinicians. We sometimes look back on what we were doing and go, it's funny to think of being so junior. And we've both sort of, we've been through a lot, I guess, since then, and both done trainings and, the kind of learning curve, I think, has been ongoing. But it's nice, yeah.
Yeah,
It's nice. I think guiding together,
yeah,
it can be a real make or break experience for clinicians. And in our case, it's been a kind of making of the relationship. I think we spent so many hours together in the room guiding people. And
and we have a really lovely friendship as well, which is lovely. Yeah.
Can you give me some examples of how your process of getting to work with each other was like as co-therapists?
I mean, I think actually what happened in our trial was that there was an idea of there being a lead guide and a co-guide, but we sort of intuitively just started really just sharing it together, and that just felt like the right way for us to work. And I think we both had different experiences that we were bringing and then together it almost made a qualified psychedelic therapist, but not quite.
And how did you start to pursue a career in psychedelic therapy and research?
I suppose one of the first things that comes to mind for me is going to a talk in London with a woman that had suffered with acromegalia, which is a condition which makes Roberta's a psychiatrist, you'll probably be able to describe it better than I can, a doctor, sorry, but it's a very, very severe physical health condition which can make parts of the body keep growing. And she'd gone and she was doing a talk about having gone to the jungle and taken ayahuasca and all of the kind of lessons about taking care of herself and her body and her mental health that had come through this very kind of intensive journey with a kind of ayahuasca healing process. And it was really very inspiring to hear that, and kind of just a bit, I don't know, it felt very different to the other kind of healing challenges that I see in our own kind of mental health system. And yeah, I found it very inspiring. So I think that for me was a bit of an entry point of like, how much might be possible in terms of other ways of thinking about mental health and healing.
I think for me, it was something that I was very interested in when I was younger. I remember reading sort of different psychedelic books, and I had been living in New Zealand at that point and was sort of travelling a little bit before I went back home to Ireland. And I remember reading about all of the research that David Nutt was doing in London, and at that time it felt like a very sort of faraway ivory tower place that you read about but never get to. And then, to be honest, I had lost interest in it to some extent, and I moved to London, and I was training in a place called the Maudsley Hospital, which is a psychiatric hospital, and there's a Maudsley Psychedelic Society there, and a friend of mine, one of the trainees in my course, was very involved in it. And I have to say I was a little bit unsure at that point. But the Imperial team were looking for female guides because at that point psychedelic therapy was quite predominantly male. There was a lot of male sort of neuroscientists and researchers doing the guiding at that time. And they were really looking for having kind of male-female guiding pairs. So I went and met the Imperial team one sort of evening. I think it was after Brexit had come in or something. We'd all been up all night watching the news. And I just got on very well, I think, with Robin and Ros Watts. And quite randomly, I was going to guide one person. And quite randomly, maybe 6 months later, Ros just offered me a full-time job. And, you know, I almost feel bad saying this because people are so sort of scrambling to get into psychedelic therapy these days, but I really wasn't sure if I was going to take it. So I read a book, Therapy with Substance, and starting to read that. And then I guess, you know, I started maybe exploring things a bit more therapeutically in that way myself. And we did sort of holotropic breathwork training as part of the Imperial, and I sort of really just came around to that kind of way of working. I think probably a big motivating factor for me also was that I was extremely sort of burnt out and finding working in sort of mainstream psychiatry really, really challenging. So it also just felt like a fresh of breath air to be able to kind of think about things in a different way.
Yeah. So you're both therapists in psychedelic trials, and you're also therapists who have been working in other modalities, but a related topic is like, what is the role of the therapist in psychedelic therapy? And why should you even have a therapist?
Well, I think that the first thing that pops into my mind is around the different conceptualizations of psychedelic therapy, the different theoretical models. So psycholytic therapy or psychedelic therapy is what first comes to mind, I think, and how differently they position the role of the therapist, and how perhaps in psychedelic therapy the action of the drug is seen as primary and perhaps more important than the role of the therapist. The therapist is kind of placed in a position of creating the conditions of psychological safety rather than holding a therapeutic process or engaging in a therapeutic process. Whereas in psycholytic therapy, I think the role of the therapist is much more what we would think of as a therapist's job, and the drug is more an aid to the therapeutic process. So the drug is kind of helping the therapist do the therapy work rather than the drug doing something that the therapist supports. So I think there are different ways of thinking about what the role of the therapist is. Yeah, I don't know. What do you think, Roberta?
What was coming into my mind, I guess, was just this sort of constant sort of balance or exploration that we're all doing around dependency and autonomy. I was thinking about how, in some ways, what is, beautiful about psychedelic therapy is that, especially if you think about people sort of being their own therapist with the psychedelic, and that kind of way of thinking about maybe the therapist being more of a guide and supportive, there's something that sort of is quite empowering in a sense for somebody sort of healing in that way. But then there's also something I think really important about people being able to depend and relate on others. And sometimes I think maybe the kinds of people who are drawn to things like breathwork or psychedelic therapy are the kinds of people who are slightly wanting to heal without having to get into that slightly uncomfortable, messy attachment sort of, therapy dynamic. And, probably would all need to shift in different directions of that, autonomy and dependency in our lives. And some people will need to lean into one, despite kind of them maybe not feeling like it's their natural inclination. I was thinking a little bit about how I think they've shown that people with an anxious attachment style are much more likely to have a sort of mystical, connected experience. Yes. So obviously we do both think that there is a role and an important role for therapists in this work. But what that role is, I think maybe ideally would be catered for each patient and kind of what they sort of are needing to work on or foster in themselves maybe.
Could you give some examples of how your work would be different if you have some patient that might lean more to autonomy than dependency within the relationship?
Yeah, I mean, I suppose what we did see sometimes coming into the study were people who found it very difficult to open up, be vulnerable, be soft, be, in the room. And what we got instead were their more hard defenses. So perhaps a lot of sort of shame and anger or, people who perhaps something came out in the relationship, you're not caring for me, you're rejecting me. And those, I think, were all ways to move away from the vulnerabilities inside. So those kinds of people, I think, actually, it's quite helpful to do a lot of relational work to make them to feel safe, in a sense, to kind of be vulnerable, to be open, which is sort of very, careful work to do and gentle work to do. Again, another balance that we're always trying to strike is, as you always are in therapy, respecting someone's defenses, when do you sort of gently push through, not wanting to push too hard and not, I guess, wanting to use psychedelics as a kind of sledgehammer to break through a wall. So I think we're maybe advocating for things also going slowly and gently, which is a bit hard, obviously, in research trials when everything needs to be done kind of yesterday. So, yeah.
So, and this makes me think of your paper on the effect of the therapeutic relationship on both the experience of the patient during the psychedelic session and also the outcomes. Could you tell me a bit about that research?
Yeah, so in essence, I think the idea of the research came from the fact that I was doing a lot of the screening for people coming into the study. So myself and Johnny and Ashleigh, actually, you ended up coming in as well to help because it was such a sort of intense job actually trying to get people, with enough numbers to get into the trial. And there was something about, I guess, being in that position of trying to, choose people and pick people and then sort of watching their trajectory, that I started to get really interested in, in a sense, some people were sort of sailing through, having these kind of psychedelic experiences that you would, expect people to have, the ones that you kind of hear about, people doing interviews and podcasts or read about in newspaper articles. And then people who were having much more kind of complicated journeys, like the kinds of examples that I was just giving a moment ago, and trying to figure out sort of, who is responding to psychedelic therapy and why or how. And one of the things as a team that we kind of started to talk about a lot was that there was something about how the relationship felt between us and the participants. So if it felt quite safe and clean, actually, is the word that comes to mind, and that there was a lot of trust. Often their psychedelic experience, in a sense, you could say, seemed to flow. You know, that they would be able to go in, open up to vulnerabilities, work through things, you know, process sort of difficulties, maybe get in touch with love, you know, and they would often feel better by the end. And then there were people who the relationship seemed much more, challenging and complicated, and that we were working quite hard to build trust and safety, that seemed to maybe have much sort of rockier journeys. And you could think about the relationship, you know, as just being a marker of complexity, in a sense, of how much trauma, you know, how much relational trauma has someone experienced. And so, in essence, I just wanted to look at how the relationship interplayed with the kinds of experiences people had, which we were looking specifically at mystical experience and emotional breakthrough, which are two sort of common measures looking at sort of the experience of people on psychedelics and how that linked with outcomes. And in essence, what we saw was that people who felt much safer in the relationship, who kind of trusted us, who had kind of good feelings towards their guides, would then often have, you know, more emotional breakthrough, more mystical experience, and ultimately had, you know, much improved depression scores by the end.
And if I remember correctly, you did 2 psychedelic sessions, right? And then emotional breakthrough in the first session would also impact the relationship. Was this something you noticed, and how do you account for that?
Yeah. So in the 2 models, what we looked at was almost that emotional breakthrough seemed to have a bit more impact in the first dosing session and mystical experience in the second, which was interesting. And emotional breakthrough seemed to have more of a kind of reciprocal relationship, that if you have greater trust, then you have a more emotional breakthrough, then you have greater trust afterwards, which sort of makes sense, that you're sort of processing and working through difficult feelings with someone, they're with you, they're supporting you. That you would then feel kind of greater sort of, safety and trust towards your guides after that as well. Yeah.
Maybe we should define emotional breakthrough and mystical experience for those who don't know.
Yeah. So I guess mystical experience is probably one of the most commonly measured things. And that's sort of kind of more like transpersonal, but also very connected experience. So a sense of ineffability. Often people have sort of a noetic, I guess, sort of quality to it, feeling kind of connected to a higher power, or, you know, these kinds of things. And I guess emotional breakthrough is probably a bit more similar to what you would see in ordinary therapy. So maybe accessing, you know, difficult emotions or memories, having a new insight, sort of working through things. And I think what's sort of a particularly important nuance about the emotional breakthrough inventory is that it kind of what it captures specifically are these things being worked through. And that's to differentiate it from what we might think about as a more sort of challenging experience, where you might get stuck in difficult feelings. So particularly it's about them being worked through and processed, which is what we would see as being often, you know, when people are able to lean in and work through something in their psychedelic experience, versus them sort of resisting or moving away, and then they might still be kind of carrying it afterwards.
Yeah. Could you tell us more about that, like working with the challenges?
So we had an amazing supervisor called Tim Reed, who, really looked after us and taught us a lot during PsilocybinDep. And I think he really taught us that there's always something to be worked with in the room, and it just might not look like what you expect a psychedelic session to look like. It might be harder to spot. And I guess the challenging experiences, I mean, you could sort of think about them in loads of different ways. But I suppose they're sort of just the kind of common sort of ways that people might resist is sort of one thing, which is that could be someone who's saying that they have, you know, that they're not experiencing much, that they're not able to kind of give in to the experience in a way, laughing, talking a lot. But then I think there's the more sort of clearly negative experiences.
Yeah.
So that could be something like a paranoia or an anxiety. It could be sort of feeling stuck in very difficult, dark feelings. So maybe a very sort of grey, stodgy depression or very difficult memories, I guess a typical feeling is often that people might feel that they're losing their mind, that they're never going to come back to their sound mind, that kind of thing. And I think what we, were really encouraged to do during the study is to get people to lean in towards difficult feelings, and despite what obviously in lots of ways would be all of our natural inclination to lean away and to get away from it. I think that is how psychoanalysts and psychotherapists, some psychotherapists work, depending on your therapeutic modality. But I think in mainstream psychiatry and maybe things like CBT, there's a real sort of idea that difficult feelings are bad in a way, and that we should sort of be trying to move away and eradicate them, rather than them maybe being something, to be processed or something to teach you, or, So that was the kind of the model that we worked with, was that sort of, it's like, in and through, I guess, as Bill Richards said. But I don't know, Ashleigh, you might have things to add.
Yeah, no, I completely agree with you. And I was just thinking that from the perspective of the therapist, I think that's where the psychoanalytic thinking is also really helpful with the challenging experiences, because just like the participants, I think in the role of the therapist, you can want to move away from that challenge that's arising in the relationship and what's difficult. So I think there's a real place and an important role for psychoanalysis in supporting the therapist to make sense of what they're experiencing in relation to the patient's experience. So one of the things that Roberta talked about last night was a patient who, kind of had this experience of not having any drug effect, and then thinking that she's being let down. And that experience for the therapist can be one, if you kind of step into a projective identification there, that you can become the punitive parent that is forcing the person to keep going. Okay, you didn't get the drug, but you've got to stay in the study and you've got to complete it. And actually it might be really important in that moment to be able to spot that dynamic is arising, to process any feelings of wanting to push the participant through the study, and actually to step back and be able to work with the relational dynamics that are occurring, not necessarily in psychedelics with interpretation, because that can be, I think, quite intrusive when somebody is under the acute effects of the drug. But I think for the internal processing between the guides in self, I think it's a very holding theoretical framework that's quite important. I don't know how you do it without it, actually.
Yeah, I think that the the countertransference and the projections, all of these kind of complicated feelings that you end up carrying as a therapist, if anything, are amplified in psychedelics. So I think obviously it depends on, the complexity of the person you're working with, but certainly I think you can get into very tricky and sticky territory if you're not able to do the kind of work that Ashleigh was just sort of describing there, in yourself. And also, really, I think it's important, especially with psychedelics, because people do go to such deep and intense places that you've done a lot of your own work. Because if you're afraid of people going to a very darkly despairing place because you've not been there yourself, or you can't tolerate it in yourself, then it's very difficult, obviously, to sort of be there to support and guide somebody.
So I suppose that's what's different with psychoanalytic training compared to other kinds of training, that you would need to be in your own therapy just to be a traditional psychoanalytic talking therapist, whereas maybe in other therapeutic modalities you don't have to have gone through your own therapy. So I think it's really, as you're saying, really helpful for that, to know the places within yourself so you can see them in the other person and feel confident, maintain confidence throughout the therapeutic process. With psychedelics, because it's so intense and so challenging, the participants need to know that you can handle it.
And how would you train therapists to be able to manage these complex feelings? And do you notice any challenges with working with therapists in different modalities than psychoanalytic or psychodynamic ones?
So here we start to get into the territory of, is it personal qualities, or is it specific therapeutic training? Or, what is it that's really important and matters the most? And I don't think we have the answers. I don't think there's strong evidence out there for what really makes an effective therapist. We've got some ideas about it.
I guess we can maybe speak to our own experience a bit. So I think just thinking about, there's so many factors, obviously, but I think for me, it has been a combination of being very lucky to have really amazing supervisors who I have enormous respect for, learning from our peers and colleagues. And, you know, the experience of being in the room with participants and patients and how much we learn from them. But also, I think, doing my own therapy, having my own experiences, I don't think that it's possible, well, for me anyway, I don't think I'd be, you know, close to the same kind of therapist that I am now without having done quite a lot of that. I mean, you know, I'm quite lucky, I suppose, that it's quite, you know, it's sort of inbuilt into my training that I, you know, am in 3 times a week psychoanalysis. And yeah, I don't think that's necessarily vital to do, but it's certainly, has taught me an enormous amount.
And I think some of the people who are listening might either be practicing therapists themselves or studying to be a therapist. So what are some, you know, things that people who wanting to get into this work should do to, you know, prepare themselves to do maybe psychedelic therapy?
I think we would both advocate for a quite strong base of like traditional therapy training.
Yeah.
I think having those kind of clinical skills of being able to just speak, hold space, you know, build a relationship, think about the relationship, you know, think about your own sort of feelings, your countertransference, what projections, what enactments, you know, all of that stuff, I think is really important. And then I guess, you know, I have to say that I have worked with somebody in a psychedelic therapy trial who had no experience of any, you know, so in Imperial, we don't actually have funding to do psychedelic training, although of course, you know, people will be personally interested in that kind of thing and find their ways. But I guess in terms of official training, we used holotropic breathwork. I know some universities will get funding for to be able to give the trial therapists psychedelics. But I have to say, for me, I think there is something important about having those kinds of experiences, and ideally the kind of experience that you're administering. The same as, you know, we'll say people will, you know, if you're going to do 3 times weekly psychoanalysis, you should do 3 times weekly psychoanalysis. But I have to say that I have worked with a therapist who had no experience of that whatsoever. And I think if I was going to choose somebody who was a really experienced therapist or a really experienced psychedelic, you know, somebody who's, you know, a psychonaut or whatever, I would put a therapist into the room.
Yeah, because I think all of that helps you to get a sense of how you as a therapist act out in the relationship or can act out. And I think that's what you need to get a handle on. You need to, because you're going to be pushed to the limit in all kinds of ways once you've got a psychedelic in your therapeutic process. It really ups the intensity of normal therapeutic dynamics. So I think anything you can do to increase your level of awareness of yourself, how you act out and how you respond to different people in different ways, that's all going to stand you in really good stead for when things start to get really intense, that you can stay steady and stay helpful rather than acting into something which isn't helpful for the patients. And
this maybe goes into the work you've been doing, facilitating discussions with other therapists, working with ethical challenges. Could you speak a bit more about, you know, the tricky ethical challenges of working with these substances and how a therapist might manage them?
Yeah, of course. I mean, there are so many to think about. I think, like we were speaking about last night, boundaries is the very first thing. In ordinary therapy, we see our patients once a week. Maybe some people see them a little bit more than that, but, you know, there often isn't any contact between sessions and it's mainly once a week. So that's a very small amount of very boundaried contact. And then in psychedelic therapy, you're seeing somebody for a series of preparation sessions. You're then with them under the effects of a psychedelic for 8 to 10 hours. And you're then seeing them again the next day. So sometimes 3 days in a row, lots of hours. A psychedelic that's dissolving all the boundaries in their mind and between the two of you. So it's a very different terrain to be walking in with a patient. And I think as best you can, kind of setting up the boundaries in advance of that is helpful, but it's it's not possible in the same way, and patients don't know what to expect in the same way because it's so different. People can have mystical experiences, and how well trained for that are we as therapists, you know, and there's other issues around touch as well. We don't have lots of training around touch, so I suppose we're thinking a lot about that. And
how would you think about that?
So I suppose I do see a very important role for it in terms of grounding in challenging experiences. I think there's something about when somebody is struggling with really intense emotion and they might not be able to communicate verbally very well what they're experiencing or to take in verbal information. So there's something really powerful about a very grounded, supported hand holding or hand on the shoulder that communicates you're safe. So I think there's something quite powerful about that. But then I think we have to be quite humble about where our training limitations are. And so personally, I'm not really highly trained to work with lots of different kind of somatic modalities. So I think there might be a wonderful, fantastic place for them and they might be really helpful. But if I don't know, or another therapist doesn't know how to use them, I think we need to be really cautious about why we would be, asking ourselves, why would I be doing that? Why am I using this?
I was going to say, my feeling is that in terms of touch, because I think especially when people are, maybe trained in holotherapeutic breathwork, where there's a lot of working with the bodies and there's sort of an appetite in a way for there being a lot of physical work and body work and, things being trapped in the body. But my feeling is that if this is legalised or, brought into a kind of therapy or, mental health system, that there won't be a lot of touch used. I think it will be a real, a little goes a long way, less is more. We had a thing called the platonic hand hold in Imperial. Even I think hand holding might be seen as somehow a little bit too intimate. So I think we should keep some touch, but I imagine it'll be very limited. But then people who do, I guess, want to go and do something, more intensive or more like a body work, that might be more the domain of retreats or something like that. That is kind of how I would imagine it panning out. I just think it's so complicated when there aren't clear boundaries. I feel like those kind of boundaries have come into, because I think you found a paper, right, where there was some touch originally in talking therapies.
Yes, yeah.
But sort of it reduced until it was gone. I feel we probably landed there for a reason.
Imagine how confusing it can be, to especially when we have a system where in ordinary talking therapy, we wouldn't hug our patients. And then suddenly they're in these boundary dissolving states. We're in a non-expert position. We're more human with one another and then we're hugging. How confusing that is for somebody, And in terms of then when the therapy relationship comes to an end, how absolutely painful and confusing that is because you feel like a friend. And maybe that's really helpful, but also it really does increase the pain, I think, of the ending for people.
But then just what came into my mind there was that I know just personally, I've had really powerful use of touch in my own experience of holotropic breathwork. It's a complicated question.
Actually, it's true. I just thought of one of my own experiences of almost feeling reparented by a touch. The use of touch in a therapy. And so, I think it comes back to being slow and cautious and grounded and honest with ourselves about what we do and don't know and how we might make things worse as well as better with the use of touch. So lots more exploration, I think.
And obviously, it just brought to mind as well that, of course, one of the really big sort of ethical dilemmas and one that's sort of been really sort of, I guess, publicised and talked about are these sort of, transgressions, sexual abuse, romantic relationships, which, has been an issue in lots of therapies, but obviously has been highlighted a lot in psychedelic therapy. So, it's kind of balancing those two. Yeah.
It's balancing, isn't it? Like people who've been sexually abused in childhood, we know are at greater risk for re-victimization. So they may be particularly vulnerable in a therapeutic setting where the boundaries start to get moved and there's more touch. And actually we do need to take that really seriously and think about that.
Yeah.
Yeah, because they are boundary dissolving, the treatments.
Yeah.
So we yesterday we went in a little bit about because of certain setting, the therapist and the institution where the study or treatment is being implemented in might affect the experience and content of the patient's story. So you mentioned maybe you at Imperial get more emotional breakthroughs, while the Johns Hopkins people get more mystical experience. But this also goes into like the ethical challenges, right? Of what the therapist has to know about, like, their impact on a very personal, deep experience of the patient.
I think it's complicated, because I suppose you could also say that about ordinary therapy in a way. Someone comes to me
sure.
and I work in a psychoanalytic, psychodynamic way. I don't give them CBT, and that's a particular sort of way of relating to yourself that in essence I'm sort of trying to train them in. And that's, obviously in lots of ways me sort of pushing a bit of a worldview onto them, that emotions are good, leaning into your feelings rather than maybe a more CBT worldview, whatever. Obviously, I think we wouldn't want to sort of be manipulative or overly priming, and I think it's always important to follow your patient and to give as much space for their experience and how they're relating to themselves. But I also do think often as a therapist people are looking to you for guidance, and I think there is a reality that people, are the experts in themselves. But there is also another reality that we have done a lot of training. Before, I've often sort of not wanted to own that in a way because somehow that felt not quite right. But more and more, I think, well, actually, I do have knowledge and skills to offer.
Yeah.
So I think probably also with psychedelic therapy, I'm also moving into a bit of a position of sort of saying, well, I do have my way of thinking about things. I have my way of working. I have my understanding of psychology or psychotherapy or, the mind. And that's the framework in that I work in. And I think I was saying last night, there's an idea in anthropology of positionality. So rather than pretending that you're this sort of blank, unbiased screen, just sort of owning, saying, these are my biases, this is the way I think about things. And then I think people who want to work in that way will come to you. So that's kind of, I think, where I'm sitting with it a bit more. That I think I'm much more about the personal than the transpersonal. And although I think it can be really beautiful and helpful to have a very deeply connected spiritual experience, I also think if you're not doing the personal work, then something will get missed. But again, that might be just my bias. That's kind of how I see things. But there's no point in me pretending to be another kind of therapist because it's kind of inauthentic in a way.
So rather than act that there would be such a thing as, a neutral psychedelic therapy, we should just own our biases and ideas and trainings.
Yeah.
Do you agree with that?
Yeah, because then in a way, the more honest you are about who you are and how you work, the more people can either say, oh, that's not the kind of psychedelic therapy experience I'm looking for, or, oh, no, that's exactly what I'm looking for.
Yeah.
And because there'll be loads of people offering loads of things, there's going to be a lot of diversity, I think, in the field. And
yeah. But maybe like the self-reflective capacities that are, offered in psychoanalytic training might be particularly helpful to, own your own biases and feelings and not be unconscious of them.
Yeah.
And I suppose the other thing is that we need to be honest with people about the suggestibility, the heightened suggestibility that happens in the psychedelic experience. So if you choose our worldview, then you might be more likely to take that on, and that's part of that whole process also of just letting people be able to make an actual choice about what they're getting themselves into.
Yeah, but this also goes into like maybe one of the biggest ethical challenges with these treatments in general, because they do change worldviews. And how do you get informed consent for a major change in how they view themselves or the world?
Yeah,
it's not really possible, right?
It doesn't seem really possible, does it? It's certainly not something I feel like I have an answer to, but it's a major issue. It's a major problem, because how they, people, particularly with the mystical experience, people change from feeling or having been an atheist and then feeling that they have a religious experience and that now they have a religious worldview or spiritual worldview in some way. So that's major. That's a major, major change. I think we are doing our best to try and tell people that can happen. but whether that constitutes informed consent, because you can't experience yourself as a spiritual person before it happens, you know, so it's complicated.
Yeah. But isn't this a challenge within trials where like the time allotted for integration can be quite limited for such a major life change? Wouldn't you need to work with that maybe for a while?
Yeah, definitely. I think it's always a challenge to work with anybody for 6 or 9 weeks. I mean, we both generally do quite long-term work in our NHS jobs, which is the UK healthcare system. So 6 weeks is how long I might assess somebody to come into therapy, or it's a very tiny. Obviously, the psychedelics are sort of catalyzing a much different process. I'm trying to think though. I mean, I personally didn't guide anybody who the issue was sort of a worldview change. What they might have is sort of maybe a new, we had a couple of people with new memories of abuse. We had people maybe have different ideas about their relationships or sexuality. Obviously, we always try and encourage people not to make any major changes. So not to end a relationship or quit a job or move for a significant time period. Because I think it's one thing to be in a new mental state and to be feeling or thinking something new. And it's another thing to actually act it out in a way to make a major change that you can't take back. But I think it's fair. I mean, for me, I would love to be able to work as a psychedelic therapist, with the psychedelic sessions in a quite long-term therapy. But then, people did do quite well. The majority of people, were feeling really good by the end of 6 weeks. So,
yeah, and just also I was thinking back to some of the patients that we've worked with and thinking about some of the people who, again, maybe it wasn't like a major shift in worldview, but did have major shifts in perception of themselves in relationship to others in their lives. And, working through enormous grief or coming to a place of forgiveness or acceptance, compassion or understanding for, really, really difficult experiences that have happened in relationship with others. And then being with somebody in those can feel really, really beautiful as a therapist, to really witness they've made a really enormous shift in their internal experience of something like that. So that can also be really, really beautiful to be with.
And what are your thoughts about implementation, and how can people get access to these treatments, and how can they be delivered in the most ethical and effective way possible?
I think that the reality is that this psychedelics are going to be given in the context of all kinds of therapies. And as much as I have my own bias and ways of working, I'm actually quite open to them being given, who knows, maybe it'll be systemic family therapy, group therapy, in the context of, intensive psychoanalysis, CBT, ACT. And I think it's really important for us, rather than to get into, because I think there is often this kind of which therapy is best for psychedelics question around, and that we could all kind of get into a bit of a battle. And there is a bit of that kind of battle that goes on now, even between different therapies. And there's a reality that there's only so much funding to go around, in a sense. But I think that, the kind of person who wants to do an intensive long-term psychoanalysis and the kind of person who wants to do a short-term CBT therapy are two different kinds of people who probably, like to think and work, and, they might suit that person in different ways. And so I really believe in sort of patient autonomy. But I suppose one thing that I would worry about is that I would, from what we've been saying before, is that we do feel, because things are so, I suppose I would probably say this even about ordinary talking therapies, that it is really important for people to be quite skillful around the relationship, around, transference, countertransference, enactments, projections, because it is so powerful and amplified. And even if you think about being in a room with somebody for 8 hours sober, you just can't keep things together in the way you can in a 50-minute session. So I do think it's important for the therapist to be quite skilled. And I do think they need to be skilled in those areas, regardless of what kind of therapy they're delivering at the end of the day.
And do you think that, despite all that, when these treatments are implemented, if it will be like a challenge to have any therapeutic component at all, like for cost-cutting reasons?
I think there might be a push for that to reduce the therapy, and I think the psychedelic therapy model at the moment is kind of reducing the therapy as much as possible, but I'm not sure how much that's an artifact of the randomized controlled clinical trial process, where you need to isolate a drug effect, and so you reduce everything else, including the therapy, in order to fit this model that it doesn't really fit very well into, to get approval of the drug. So I don't know if it's just like that right now, because I imagine once you try to translate that into clinical practice, inevitably, like every time we try to translate something therapeutic, you know, in terms of therapy from clinical trials into clinical practice, it doesn't work in the same way, and the clinicians will see that it needs other things and the therapy is really important. And so I struggle to imagine that it's going to be possible to really safely reduce the therapy to that much. Yeah. And if it does, we're going to be working with a really limited pool of people who are able to tolerate that. So patients who are able to tolerate a really, you know, because people out there do take psychedelics in a self-experimentation way and they're okay. So we know there are people who that's okay for and that might work. But it's really unethical to create a treatment that other people might benefit from, who need longer treatments, who need more skilled therapists. And they might benefit from that treatment if we're able to offer it in different ways. But we limit access to them because we create a model which has too little therapy in it. My hope would be that we, at the very least, acknowledge that we're going to need a stepped care approach to this. So whilst there might be a model that has very little therapy, there are also going to be a need for models with lots and lots of therapy.
Yeah. So to finish up, we have some final questions. But so how have your views on the field changed as you've gotten more experience working as therapists and researchers? And
certainly, I think in some ways, again, you know, much humbler in a sense of all that I don't know and all that there is to learn. But then in other ways, I think seeing, actually, we've learned quite a lot from when we started working, you know, inside a DEP. I think I have probably moved slightly more towards the importance of the relational, the kind of ordinary, drudging, sober work of therapy and how important that is. I think we, from our own experiences of feeling a bit out of our depth and seeing things not go wrong, but sort of, you know, seeing how complicated that work can be, have a bit of a feeling of maybe a responsibility that, you know, it's a very small profession. And as much as I don't think we consider ourselves to be particularly expert or experienced, there is a reality that we do actually have some experience, which is more than what most people have, because we're so new and so starting. And so obviously, you know, working a lot with taking in the voices, I think, of all kinds of people, participants or underground workers or, you know, really experienced therapists that we're lucky to have in our professional network, or people working in more shamanic or mystical ways. A bit of a responsibility, I think, to try and share our learnings and think about what we can do to keep things safe. Maybe it's a bit of a grown-upping. When I look back on us in Solid Dep, but you know, I feel like we're young. So yeah, something like that, I guess, is probably a bit of the trajectory that I see in myself.
Yes, I can definitely relate to that. I think I was just sitting here thinking about diagnosis, the word diagnosis going round and round and round in my mind. You know, we were working in a clinical trial that was diagnostically driven. So we were bringing people in with symptoms of depression. We were assessing for depression. How did their depression change at the end? And I think, I don't know how much I subscribed to the diagnostic system beforehand, but I think I am a really non-diagnostically driven clinician at this point. And I think psychedelics really could not care less about what your diagnosis is, you know.
Yeah.
You know, they kind of just, they're transdiagnostic. They work across the spectrum. And I find that absolutely, utterly liberating and wonderful. And I think what it's also more and more and more highlighted for me is the role of childhood trauma, which is why that's become my specialist interest in this work, and how do we work with that and those people who've had really significant early childhood trauma. So yeah, I think that's been probably one of the biggest learnings. Also just how much we need each other. So I suppose that's what we're talking about lots and lots with the patients. We want to give them a relational experience which is reparative and supportive. But I think also, I've learned that as a clinician, I need to be with others who think alike. I need to be with others who challenge my thinking. I need to be held and supported by others and to hold and support others. So I think those have been the really, really big learnings for me.
Great. And what do you have coming up in terms of research into psychedelics? Because as I understand it, you're not doing that currently.
Yeah, so I think we're still... I have probably slightly moved. I mean, I wasn't doing, I was working on a trial, but I've never been somebody who's written sort of loads of papers in that sense. But I think that we are both still sort of actively thinking about this sort of idea of kind of ethical and clinical challenges, sort of conduct. We published, so Meg Spriggs, one of our colleagues from Imperial, who's actually returned back to New Zealand, and Ashleigh put together what's called the ARC framework, which is the idea of access and the idea that people who are maybe sort of different socioeconomic or in this way might have the most difficulty accessing psychedelic therapy, and of course might be the ones who need it the most. Reciprocity, which is around sort of our relationship and how we interact with obviously the communities and cultures that have been using these medicines for decades and years, and how we can kind of respect that in a sense. In a kind of real way, I think. And also conduct, which is the arm that we're most interested in, which is sort of this idea of these ethical and clinical dilemmas, writing kind of guidelines and, having, groups where we can think about these things. So we published the first paper of that a few months ago this year. And then each of those arms is going to write a specific paper. So there'll be an access paper, a reciprocity paper, and a conduct paper. So that, I guess, will be something that we'll be working on. And then we're also going to be writing papers about some of those more specific areas. So maybe, specific papers looking at sort of specific kind of tricky topics or tricky dilemmas, using kind of case material from our experience in Psychedelic. But I think we're both a bit slow sometimes. Actually, I'm just slow, I think, because
that's how it is in the academy.
It's very slow.
Yeah. But actually slow for good reason, which she can fill you in on. She's not slow. She's just busy doing other things.
So I am doing quite a bit of qualitative research.
Yes, and that is slow.
It's very slow. It's very slow and long and winding and wonderful. I love it. And Roberta will be helping with some of that as well. So I think actually one of the other learnings for me from being part of the randomized controlled trial process, I think the outcome studies are really important and they serve a very important function. But what I've also realized is maybe where I can contribute and where we can contribute as clinicians is in the psychotherapy process research, because actually outcomes studies which tell you how symptoms are different after the treatment compared to before the treatment, they don't tell you how to support people through the treatment. So that's the area of focus I've been looking at, kind of analysing therapy sessions and looking at the process. What are clinicians doing? What are patients doing? What works? What doesn't work? So I'll have some research coming out soon around that in relation to working with traumatised populations.
Oh, exciting. Yeah.
And then also qualitative research with patients who've been in treatment with psilocybin for anorexia and with DMT for depression. And Roberta will be helping with those as well. So to kind of see what is their experience and think about how we might improve the treatments, change the treatments, what's working really well. And I think we're also going to potentially both be guiding on a study that's coming up with chronic pain as well. So,
exciting.
Yeah, there's lots going on. Lots going on.
Yeah.
And finally, do you have anything you would like to say to any students, clinicians, or researchers who want to get into psychedelic research and treatment?
I think it's hard because it's gotten so popular, and there's so much interest in it, which is amazing. But there is a bit of a bottleneck, I think.
Yeah.
But I knew a gentleman asked this question last night, and I was, I think before you could kind of get in the back door a bit, and you know, if you were just really interested or really experienced in a way, you could kind of find your way. But I think as it's becoming more official, in a sense, I think people are going to have to also go down sort of more official channels. So of course there's lots of ways to get involved. I mean, you know, my mind of course would automatically go to clinical, but you could be interested in the neuroscience or the research, or you know, the advocacy. You know, but I guess we can probably mainly speak to the clinical side of things. And I think I would say to do your ordinary clinical skills training, be that, you know, a psychology or a therapy or, you know, whatever. And also, you know, in whatever modality you're interested in, I think, you know, you could be group, it could be systemic, you know, because I think that psychedelics will come into all of those areas. And after that, I think I would say it's important to do your own work. So maybe to try and seek out, if you can, obviously, different legal restrictions. I mean, it's funny for people trying to train in something that is technically, you know, illegal outside of research. But, you know, it could be a breath work or meditation, sort of just try, you know, and of course people can go abroad for retreats or that kind of thing to get as much experience as you can, I think. And then there are, you know, loads of new sort of specific psychedelic therapy trainings, in a sense. I think some retreats will maybe let you come on as like a volunteer basis, and you could get a little bit of work guiding. And another thing that a lot of people do are those groups that do the kind of psychedelic safety care things at festivals. So people will come into I should have said this last night, actually. I didn't think about it. People will come into tents, sort of maybe if they've taken you know, too many drugs or whatever. And again, that's quite a nice sort of quite fun way, because I think you get free tickets to a festival as well, of learning a little bit and seeing if it's something that you're interested in. So yeah.
And what about you? Some advice for people wanting to come into the field?
I think I agree with everything Roberta's just said. I think anything that if you want to be doing guiding work, if you want to be a therapist in the room sitting with patients, I think anything you can do to build up your capacity to be able to sit for long periods of time. Presence. I think cultivating your own capacity for presence, your personal presence, your therapeutic presence. What on earth does presence mean? Kind of engaging with that as an idea and a topic. Yeah. I think that's one of the hardest things to develop, and I think it takes time. So start early, and I think it will take you a long way in this work.
All right, great. Thank you so much.
Thank you so much. Thanks for having us.
Tack för att du har lyssnat. Vi som har gjort podden heter Anja Winter och Gustav Martling. Podden är producerad av Nätverket för psykedelisk vetenskap, men åsikterna som uttrycks är intervjupersonernas egna och representerar alltså inte föreningen i stort. Läs mer om vår verksamhet och bli medlem på mpv.se. Musiken är gjord av Manne Skavenstedt.